Okay, I think we're ready to go. Hello, everybody. My name is Mike Groves. I'm an Associate Specialist and SAS Lead for Southern Health Foundation Trust. And amongst other roles, I'm a member of the College South Eastern Division Executive Committee and the College SAS Doctor Committee. I have the privilege of chairing today and have the opportunity to present a little on leadership and influencing during tomorrow's session. We are really pleased to be able to put on this webinar despite the ongoing challenges of the pandemic. And whilst we embrace the opportunity of coming together and learning virtually, I do hope that we can see each other face to face at future events. I'd like to thank you all for your attendance and today's speakers, Dr. Steve Pearce, Professor David Baldwin, and Dr. Mario Giudurena. A heartfelt thank you to Karen Morgan, the college's Southeastern Division Manager, and to Ashley Kellaway, the SAS and Medical Education Coordinator at Surrey Borders. And a special mention to Fatma Tekfi. Fatma is SAS rep for Surrey and Borders NHS Foundation Trust and co-chair of this event. In particular, we thank her and her colleagues for the initial drive in putting on this event. So a few housekeeping notes. Both days will be recorded. The video links will be made available around 2 weeks after the event and be made available for 2 months following the event. To optimize the experience, I also suggest we put our Zoom screens to speaker view. Please use the question and answer box for questions for our speakers. The chat function has been disabled for this webinar, but if everyone has a technical problem, they can put this in the Q&A box and this will be dealt with as quickly as possible. A link to a feedback form will be shared in the chat at the end of our sessions and will also be sent after the event. We would be grateful if you could fill this in for us. Attendance certificates will be sent 2 to 3 weeks after the event. If you get the urge, please tweet throughout the event using hashtag SAS 2021. There will be a break following Professor Baldwin's presentation between 2:40 and 3 o'clock, and I invite you to return promptly. So, this afternoon, we are going to hear from 3 great speakers about how to meet some of the challenges of treating and managing mental health disorders in our day-to-day practice in this changing world. Dr. Pearce will be talking about management of personality disorders. Professor Baldwin will be looking at anxiety disorders. Dr. Giudurena will be talking about treatment-resistant depression. Tomorrow morning, the focus will shift to providing a little inspiration for the potential next steps in your career. We'll be looking at developing a high-quality CSER portfolio with sessions on CSER application, influencing leadership as an SAS doctor, and your role in clinical governance. I look forward to seeing you all tomorrow. So without further ado, let us welcome our first speaker, Dr. Steve Pearce. Dr. Pearce has published and worked in the field of personality disorders for 15 years. He is head of the Specialist Community Personality Disorder Service in Oxfordshire and Buckinghamshire. He is a past president of the British and Irish Group for the Study of Personality Disorder and current chair of the College Faculty of Medical Psychotherapy. Dr. Pearce will outline some of the reasons why people with personality disorder pose some of the most challenges in psychiatry and how we can effectively work with this group. So over to you, Dr. Pearce.
Thanks, Mike. So I'm going to, let me just start my screen sharing. Is that okay? Right. Unless I hear otherwise, I'll assume everyone can see that. Right, okay, well, thank you very much for asking me to speak about this personality disorder. It's at times controversial topic, but it is difficult to manage and it's often very prominent in psychiatric work, not only routine outpatient work, but this group of people pose significant problems in inpatient care and also emergency presentations. I'm going to say a bit about that in a moment. I'm hoping to talk to about 10 to 2 and have perhaps 5 minutes for questions, anything people want to speak about in particular. So this is the broad outline of what I'm going to say. Talk a bit about diagnosis. There's been some recent changes with ICD-11. I'll talk a bit about epidemiology. It's quite common. morbidity, mortality, and comorbidity, and then talk about management, perhaps the most important part of what I'm going to say today, because it's quite difficult to do well, and because we, along with the general public, are prone to stigmatize people with personality disorder in a very particular way. So just to refresh your memory, this is DSM-5, same as DSM-4, 3 clusters, which are quite helpful. Quick comment about schizotypal disorder. In America, they think of schizotypal disorder as a personality disorder. Actually, it's not. It's part of the schizophrenia spectrum, genetically and phenomenologically, although it has some elements that remind people of personality disorder, which is, I think, why DSM has it in this category. Of course, the people that we in secondary and tertiary care have most difficulties with and present most commonly to us are the emotionally unstable or borderline group. Actually, GPs, they do struggle with the EUPD, but they also have a particular problem with the cluster C group, who are frequent attenders at GP practices. And it's worth remembering that personality disorder is sufficiently common that the vast majority of people with it are treated by GPs. ICD-11 is a very significant change over ICD-10. ICD-10 was much more similar to DSM-5. ICD-11 has adopted a hybrid scheme and introduced some dimensional elements. So the main diagnostics are dimensional: mild, moderate, severe, and unspecified. There is also a personality difficulty category. Probably 40% of the population could be said to suffer with this. This was partly introduced to try and address some of the stigma problem. Whether that will work or not remains to be seen, but it's coded in a different section, so it's not mental disorder. And then you can qualify, you don't have to, but you can qualify the mild, moderate, and severe personality disorder diagnosis with one of 6 personality domain traits, which broadly, these are informed by the genetics. So for example, anancastia has quite a strong genetic component. So this would be the main contributor to what we would have called anancastic or obsessive compulsive personality disorder. Negative affectivity corresponds to an extent with borderline or emotionally unstable personality disorder. But there was, when this was in the final stages, there was a bit of a disagreement about it. So members of the European Society for the Study of Personality Disorder were unhappy without having a rubric for borderline. And partly that's because, as you'll see as I go through today, most of the research is around borderline personality disorder. And if you don't have a rubric going forward, which you can identify with previous cohorts in which we've established what works and what doesn't help, the effectiveness of medication, etiological factors, detailed epidemiology, and so on. If you don't have a rubric that you can map onto that, then it makes that research rather difficult to use, and negative affectivity doesn't map precisely onto EUPD. So there was some last minute negotiations, DSM and ICD procedures. It's kind of like decision by committee, although it's informed by research. A lot of it is expert opinion. So there's a certain amount of horse trading, and that happened. And a borderline pattern was introduced. You can probably see in some of these other domain traits, so dissociality is similar to dissocial or antisocial personality disorder. Detachment is similar to the cluster A personality disorder, schizoid. Anancastia, as I say, is similar to anancastic personality disorder. And disinhibition is another trait domain related to cluster B, so borderline, histrionic, possibly narcissistic, but certainly antisocial. So that's ICD-11. It will inevitably be rolled out. Those of you who use ICD coding in your diagnostics and clinical case notes. This will be rolled out. It takes a few years to catch up, but this will be coming your way. There's a certain amount of emerging research about, for example, what proportion of people have each of these severities, but we're in the early days of that. So personality disorder, this is ICD-10, is common, almost 5%. So to put that into perspective, that's 4 or 5 times more than schizophrenia. Borderline personality disorder is often thought to be more common in women. Actually, it's more common in men. So the reason we think it's more common in women is because of the people who present, people who seek help, and obviously men generally in medicine seek help less. But also men with borderline personality disorder tend to end up in different places. So quite a high proportion of prisoners have borderline personality disorder, over 30%. And of course, 95% of prisoners are men. So that is an alternative route where you find borderline and of course antisocial and in particular paranoid personality disorders in prisons. They present to GPs 5 times more commonly than the general population. As I say, that is clusters B and C, but in particular clusters C cause GPs some difficulties in dealing with them. And they're generally more likely to be dissatisfied with care. And GPs often feel uncertain what to do with them. There was a survey probably 20 years ago now on what GPs call heart sync patients. And what they found was that about 40% of heart sync patients have a personality disorder, and that's the organizing principle behind their presentation. Another 40%, it's musculoskeletal, and then there's another 20%. They're more common in psychiatric outpatients, more common again in psychiatric inpatients. Some surveys have up to 70% of psychiatric inpatients have personality disorder, which is not to say that's the reason they're an inpatient. It's quite often comorbid. But as with a lot of mental disorders, there's high levels of comorbidity. And there's a piece of work here from Patton, which identified 68% of people in mental health services generally who have personality disorder have EUPD. So of that 50% of people in services who have personality disorder, the majority have EUPD. But again, it's worth remembering that for many of them, they'll have more than one personality disorder. Of people with borderline PD, ICD-10, 13% have been admitted over their lifespan, and that's obviously different for different ages. The peak of admission is late 20s to mid 30s, and that's, as I say, mostly for women. But it's worth remembering that the vast majority of people with borderline personality disorder are never admitted. And there's probably a large majority who don't even come to see their GP actually, and they're contained in more or less stable marriages, jobs, social situations, or on the welfare system. Quite often this group of people will present when something goes wrong, if they get divorced or they suffer a bereavement or a loss event, and that might be when we see them. Borderline personality disorder and personality disorder generally has mixed reviews. I think there have been feelings around in the past, maybe less now, that psychiatry shouldn't be dealing with this group of people. But actually, as I'll demonstrate today, morbidity and mortality are high, as is disturbance. It's a reliable construct. So it's much more reliable, for example, than major depressive disorder. So these are the field trials from DSM-5. So that's worth remembering. It's only reliable, though, if you make the diagnosis right. And I'm going to speak a bit about that in a moment. Life expectancy is reduced by about 20 years in personality disorder. There's various reasons for that, and they're much more prone to cardiovascular disease for reasons which are not entirely clear. Of course, there's the impact of suicide and homicide, although they're rare, but also the impact of substance misuse. And then some of the reasons will overlap with the reasons that people with mental disorder generally have low life expectancy, use of psychotropics, problems accessing care, and so on. They have very high rates of unemployment and homelessness. So this is a study which approximates to the new ICD-11 severity criteria. So severe would be severe, complex would be moderate, and simple would be mild. So you can see how disability escalates very quickly once you get to severe personality disorder. Many of this group would have antisocial personality disorder, and people with complex disorder would have 2 comorbid personality disorders. About half of the homeless population has a personality disorder. There's been 2 or 3 trials that have shown that now, studies that have shown that. There are high rates of conviction and of problems with the police, high rates of unemployment, high rates of problems in early life, so there's figures for school expulsion there. And they also have unstable accommodation. So they're much more likely to be made temporarily homeless, or be sofa surfing, or be evicted, or be in unstable rental accommodation. In general, I think the take-home message here is that it's a marginalised and vulnerable population with whom, on the whole, we don't do well. There's a strong association with self-harm, and as you'll know, self-harm is itself strongly associated with completed suicide. Completed suicide rates in people with borderline personality disorder run at 8 to 10%, and this group represents a substantial proportion of all suicides. They're a substantial number of the people presenting to A&E who, if you do on call, you will see out of hours or as an emergency during office hours. There's a high rate of medication prescription, which is particularly problematic, partly because there is no medication licensed for personality disorder, partly because there's a lot of polypharmacy. And the reason there's a lot of polypharmacy is at least partly because we don't know of anything that works for people with personality disorder. We don't know of any medication that consistently works with populations with any of the personality disorders. But of course, people feel like they want to do something for them, and so medically qualified staff tend to prescribe. They then don't de-prescribe, and that's how you end up with polypharmacy. It's worth noting, this is by the National Confidential Inquiry on the right here, that a very small proportion of the people who ended up completing suicide had been able to access specialist services. Now, there was a survey about 3 years ago in the bulletin, the RC site bulletin, BJ site bulletin, in which more or less every trust in the country said they have to have specialist personality disorder services. The real problem there is, firstly, they can be difficult to access. Secondly, they can be very small. And thirdly, we think probably trusts say they have these specialist services, when actually what they have is a man and a dog, or a woman and a dog. So how does it affect other problems? So the data on the impact of personality disorder on response to medication and therapy, mostly CBT, is mixed. There's some evidence that CBT, for example, for depression is less effective if you have comorbid personality disorder, although there was a recent trial which showed the opposite, that it's probably as effective. I think the jury is still out on this, but certainly there's quite a lot of evidence that if you have a comorbid personality disorder, There are some medications that don't work as well, and some psychological treatments that don't work as well. Of course, this may be partly related to concordance. Comorbid personality disorder makes adverse outcomes more likely. So this is a study from 2003, which found about 20% of people with psychosis in mental health services had a comorbid personality disorder, almost all unrecognized. And it increased the risk of suicide substantially. This is one of the reasons why it's important to make the diagnosis, even if it's a secondary diagnosis, even if someone is presenting with a psychotic disorder or an affective disorder. If there's a comorbid personality disorder, it affects what happens. And the third study here is a GP study. What they found is that GPs have more difficulty coping with people with personality disorder, but importantly, they're less likely to refer them. So this is likely to be linked to stigma, likely to be linked to countertransference. Even though people with personality disorder are at high risk of completed suicide, they commonly self-harm, and they make other problems more difficult to treat. Nevertheless, they are less likely to be referred on to secondary care. It's not all bad news. So personality disorder generally, and borderline personality disorder in particular, does remit over time. So there's now 24, this slide is from a 16-year follow-up. There's now a 24-year follow-up, and what you'll see, I don't know if you can see my pointer there. So this is the remission rate for personality disorder generally, and the blue line is the remission rate for borderline personality disorder. So what we do know is that over 16 and 24 years, the remission rate of borderline personality disorder, that means the number of people who no longer fulfill criteria, is 98%. Now, there's a rider to that. There's two riders to it. Firstly, it's not consistent. So in any 1 year, about a third of that group will acquire the diagnosis, or will be eligible to acquire the diagnosis again. The reason for this is because a lot of the diagnostic criteria are behavioral. So if you haven't harmed yourself for 5 years, then you may no longer fulfill criteria. But if something happens and you happen to self-harm, then you may be eligible again. So that's a kind of word of warning over remission rates, and perhaps more useful are recovery rates. And so for borderline personality disorder, these are the green lines here, and as you'll see, they're much lower. Now, recovery is a more useful metric because it covers things like social and occupational recovery. So people who are able to keep a job, people who are able to maintain relationships, able to keep their accommodation, and that lags. And importantly, it also is related to where you start. So people who have money, who have education, who are younger, they tend to do better. And this Zanarini cohort generally are more likely to be educated and have resources than the kind of people we would generally treat in the UK. So this may be an over-optimistic picture. But it also lends weight to what a lot of us would do with this group of people, which is to do work with them about maintaining their relationships, because that will affect their prognosis. There's a particular stigma that goes with personality disorder generally, and borderline personality disorder, where most of the work has been done specifically. So some of it's been done in psychiatrists, the most famous one from the 80s, the patient psychiatrist dislike. But more recently, it's been done with nurses, with psychologists, with social workers, and with GPs. And what it's found is that we entertain stigma towards people with personality disorder I've told you about how GPs are less likely to refer them. They don't do it deliberately. If you ask them why they're not referring someone, they say they think that nobody can help. But what we think is happening, partly at least, is the annoyance, that hostility is one of the traits that you get in borderline personality disorder, for example. And so clinicians distance themselves from individuals with borderline personality disorder. We make antagonistic judgments. We have more trouble being empathic towards them. So this last paper here, the Markham paper, does it get worse with training? I think it probably depends what training you get, but there is a length of service effect. Perhaps it's a kind of burnout effect. People get grumpy as they get older, and that's probably where that data comes from. There are particular markers of stigma, so we're learning a lot about stigma as time goes on, and some of the markers of stigma give us a bit of a clue as to why people with personality disorder have a particular problem with stigma. So one of the things that makes stigma more likely is the idea that recovery depends on personal effort, and that definitely attaches to people with personality disorder. If it appears to be a personal fault, and people certainly have that view of personality disorder. One of my patients said to me this morning, he said he's subscribed to a TikTok channel on borderline personality disorder. And he said there's a lot of blaming going on, which is to do with weakness of character, the idea that you could do it differently if you wanted to. And of course, before personality disorder, back in the 50s, this area was called characterological disorder. Stigma is more likely if causation is unclear or if it's thought to be self-inflicted, and in particular, a genetic or clear environmental causation reduces stigma. We see this in the kind of preferred diagnoses. If it's clear that your diagnosis is because of a particular catastrophic event, which you can point to, then it moves the fault away from you. And of course, no one's keen to have a disorder where there's a lot of stigma attached. And finally, linked to vice, the idea that personality disorder is linked to vice, which is certainly promulgated by the media, who sometimes only really report on personality disorder when it's linked to violence or aggression. So for all of these reasons, it's understandable that stigma attaches particularly to people with personality disorder. But there's an additional problem with us as doctors and our colleagues working with people with personality disorder, which is that we tend to practice defensively. There's a survey from New Zealand from a few years ago that found that 85% of clinicians, just in the year before the survey, thought they'd practiced in a manner that they believed was not in the best interests of their patients for defensive reasons. In other words, they did things that they didn't think would help the patient, but either the patient was demanding and maybe threatening, or they felt they had to do to protect themselves. So we are ourselves prone to making poor decisions when it comes to people with in particular borderline personality disorder. So you're in your psychiatric outpatient clinic, you've got 20 to 30 minutes, and you've got a patient coming to see you who you know has a moderate or severe personality disorder. You've checked your attitude, you're aware of the stigma that attaches to this group, and you're being careful not to practice defensively, to only make decisions which you genuinely think are in your patient's best interests. What can you do? First thing you can do is make the diagnosis. I think that's probably become clear from what I've been talking about today, that making the diagnosis is important if you're going to manage someone accurately and consistently, if you're going to give them good advice. But if you're going to make the diagnosis, it has to be reliable. So you need third-party informants. You should not be making this diagnosis without a third party. We're all poor witnesses, or we all under or overestimate certain aspects of our personalities. And people with personality disorder probably more than most. And for some personality disorders, for example, antisocial personality disorder, it may be even worse because people engage in deception. Secondly, it's very difficult to make a diagnosis of personality disorder on a single meeting, unless you have very good longitudinal notes. So personality disorder is normally based on a longitudinal assessment when you've met them a few times. And the diagnosis is based on longevity. In other words, if someone has been manifesting these behaviors and this internal experience for a year, then you shouldn't make the diagnosis. In general, we'd expect these problems to have been in existence for 5 years, and normally would expect them to have been in existence since adolescence or early adulthood. Thirdly, use reliable instruments. The SCID-2, which is a DSM, IPDE, International Personality Disorder Examination, which is ICD. There's some very good screening instruments now. The SAS is a clinician screening instrument, which has a sensitivity of about 85% and a specificity in psychiatric outpatients of about 80%. SAS-PD is a questionnaire, so you give that to your patients. It's very quick. The SAS takes about 30 seconds, believe it or not. The SAS-PD will take your patients probably 3 minutes. And that also, the SAS-PD maps onto the new severity criteria for ICD-11. So they're worth using, but in general, you should make use of these instruments, particularly if you're not confident in making the diagnosis. Some people are nervous about making the diagnosis because of what I just talked about with TikTok and stigma and defensive practice, which can carry with the person. Some of my patients will say to me, once a diagnosis was made, everyone treated me the same way, which was negatively. And particularly people who self-harm have quite a hard time in A&E sometimes, whether or not they have the diagnosis, but the diagnosis can make it worse. So we do know that if the diagnosis is made sensitively and you have sufficient time and you make it in the way that I've been describing, that people find it just as helpful as other diagnoses. And I think probably the movement to replace the diagnosis EUPD with something like complex emotional needs is driven by people who haven't had that experience or who, once having received that diagnosis, experience discrimination from mental health services. But making an accurate diagnosis, communicating it sensitively, comprehensively, empowers your patient. They can look it up on the internet, they can make connections with people from a community of sufferers. There are all kinds of resources out there. There's some quite good self-help resources and books they can access. They can tell their loved ones to access carer groups, and it affects the likelihood of useful treatment. And also there's a group of people who don't have a meaningful Axis 1 diagnosis. So if you're not going to make the diagnosis, you kind of end up tied up in knots and using all kinds of euphemisms. And there's a real relief. People say again and again, there's a real relief to being given a diagnosis. You know what you're in for. You know what the prognosis is. You know what kind of things help. Thirdly, use consultation skills. So I just want to pinpoint a few things. First of all, mentalization. I hope everyone here has come across mentalization. If you haven't, then look it up. It's fairly straightforward. It's related to reflective practice, but it's slightly more than that. It's the ability to put yourself into other people's shoes and to do it deliberately as well as unconsciously. So to deliberately, in a consultation, ask yourself the question, what is going on for my patient? Secondly, the ability to do that for yourself. What is going on with me? I say this particularly for people, for doctors in training who are doing on calls when it's 3 a.m. and you've got a patient who's being hostile or difficult or demanding, to check your own internal state. how are you feeling? Because if you're feeling agitated, angry, upset, anxious, it makes it much more difficult to mentalize. It makes it more difficult to accurately say how you're feeling. It makes it more difficult to accurately make an estimate of how your patient is feeling and what might be driving what they're saying to you. So if someone is pleading to be admitted or refusing to be admitted, and you're considering whether to call a mental health act assessment, if you can mentalize accurately, it gives you a way of understanding what their agenda is and how you might deal with it in a way that doesn't become coercive. Their emotional thermometer, we call it the emotional thermometer, it's a kind of useful metaphor. If they're high in the red, if they're agitated, angry, if they're in the blue, if they're anxious, if they're depressed, then they're less likely to be able to empathize, to mentalize as well. And they're quite likely to make inaccurate judgments about what your intentions are, what your mental contents are. So that might lead them to think that you don't like them, that you don't have their best interests at heart, that any of these decisions you're making or medication you're prescribing or arrangements that you're putting in place might be just to get rid of them, or might be because you're angry with them, because they're inaccurately mentalizing, they jump into conclusions, they're mind reading. So being able to take your patient's emotional temperature also helps you decide whether or not they're likely to be accurately mentalizing. People with cluster B personality disorders in particular, antisocial and borderline, we know this about, have much smaller mentalizing ranges than the rest of the population. They have more difficulty mentalizing, and when they lose the ability much more quickly when they go up or down on the thermometer. That's mentalization. As I say, look it up if you're not familiar with it. It's also one of the approaches we'd use in treatment. The rescue blame trap is something to avoid. It's akin to the drama triangle, those of you who are familiar with that. And this is a tendency we have to fall into one of two roles, either to want to rescue our patients, to do things for them, which is disempowering, or to blame them, to feel like they're not trying hard enough, or they're winding you up, they're doing it on purpose. And those two they're familiar positions to take up. And what we encourage people to do with people with personality disorder in particular is to try and take a position midway between the two, where you're neither rescuing them and saying, this has nothing to do with you, there's nothing you could do. So you're maintaining the sense that they have a part to play in their recovery in the decisions they made, on the one hand. On the other hand, not blaming them. So we call it responsibility without blame, this approach. And there are papers written about this as an online resource. You can take an online training for free. You can put it in your PDP. It's called responsibility without blame. It's a way of dealing with people. And actually, it's probably useful in most mental disorders, because most mental disorders have an association with poor decision-making, difficulty making wise decisions. And we as professionals can come to a blaming position if we're not careful. Thirdly, there are 6 steps that you can take, that you can work through when you have limited time with someone with personality disorder in your clinic. You don't have to do all of them, but it's worth knowing a bit about this, because quite often I think people, when they have someone with personality disorder in their clinic office, they feel a bit lost, and care coordinators will say this as well. They don't really know what to do. They don't know what's helpful, and they feel powerless or like they're unable to input something useful. So of course, the first thing is crisis management. No one likes to feel unheard, and if you're seeing someone and there's a crisis brewing, there may be some things that need to be put in place for crisis management. That links to the second point, which is listening and empathizing. So use your mentalization skills, put yourself in their position, check your own position on the emotional thermometer, explore the distress. What is it that brought it about? I dislike the word trigger. 3 of my patients have used that word this morning. And the trouble with the word trigger is it implies that the trigger's been pulled and it's gone off and there's nothing else to do about it. Nevertheless, the precipitants, what is it that produces this level of distress? And is there a longer term amount of unmet need, housing, money, relationships, and so on? Fourthly, to explore what helped previously. We do this with medication with people with personality disorder, but we also do it with coping skills. They quite often will come to us and say, well, I need something new, but actually what they need is to remember something old, the thing that helps in the past, the things that's helped previously. And as you get to know your patient with personality disorder, hopefully you can help them build up a repertoire of coping skills which fairly reliably work. Maintain your boundaries. It's surprisingly difficult to do, but at the beginning of the consultation, say how long there's going to be, finish when you say you're going to finish, remind people when you're getting close to the finish, try not to see people at 4:30 on a Friday, and so on. And finally, give them something. Some GPs just give them a list, give someone with personality disorder a list of addresses, phone numbers. We have lists of coping skills that we give out to people. A follow-up appointment, sometimes medication. It's very powerful to go away with something in your hand or knowing that something is coming. Prescribe or don't. There's a great temptation. I think this is one of the reasons for the problems we're having with antibiotics. There's a great temptation, of course, to give everybody something at the end of a consultation when you're bringing it to an end. And it helps to keep to time. The real problem is that we don't have any evidence that any medication helps in personality disorder generally, and where most of the work's been done, borderline personality disorder specifically. We do know that the one large-scale publicly funded trial, this one down here, found no impact. But interestingly, that was a trial of lamotrigine, MRC funded. But what's interesting about that is you'll notice that in the first 12 weeks, the BPD score dropped for both groups. Now, of course, if there hadn't been a placebo group, we would have mistaken that for effectiveness. But what that illustrates is the point I'm making, that giving someone something is a powerful intervention. And what's interesting is even though the placebo wasn't a crossover trial, the placebo was given for 52 weeks, the lower levels of distress and symptomatology persisted. So that's not an argument for giving placebo, it's an argument for giving something and for the impact of thoughtful management. The bad news is that prescribing is extremely common even when there's no comorbidity. Of course, this Axis 1 comorbidity is very common, depression, anxiety, but even when there isn't, prescribing is common. And in this group of 87% of people who only had EUPD, so the 87% of people who were prescribed who had EUPD and didn't have a comorbid diagnosis, 28% had more than one class of psychotropic prescribed and 23% 3 classes. So this is bad news. And on the right, you can see that only 72% of this group had a medication review in the year before the study. I think the principle with medication, as I say, there's no medication that has been found to work reliably. The principle is if you prescribe it, it's your responsibility to de-prescribe later if it hasn't produced a maintained benefit. Because otherwise what happens is a few weeks, a few months later, the person comes perhaps to another clinician, perhaps to you in crisis, and all you can think to do is prescribe again. And then bingo, you've got another class on your hands. We're slightly running over. So just very quickly to say, structured clinical management is a very effective intervention for community mental health teams. It needs expert supervision, but it is implemented by care coordinators. And you can have up to 12 people from an AMHT or a CMHT in this program, really doing the same kind of work that a care coordinator would do, but in a particular way, and it produces very good outcomes. And then finally, what you can do is refer for specialist treatment. So the NICE guidance from 2009 is still current. It gets reviewed every 5 years, but hasn't been rewritten. And I think probably the next time this comes up for review, it will be rewritten, partly because the recommendation that there shouldn't be any brief interventions is now getting a bit old. There's a few trials emerging of brief interventions, and what's interesting about this is they all center around the diagnosis. In other words, you won't be able to make use of them if you're avoiding making the diagnosis. And a large part of the effectiveness of these brief interventions is in psychoeducation around a reliably, competently made diagnosis. And what kind of things can you refer people to? Well, it depends what's present locally. We don't really know what DBT does, dialectical behavior therapy does, after 12 months. There's no follow-ups more than 12 months. And until there are, it's very difficult to recommend it unreservedly. MBT has mentalization-based therapy, similarly has quite a mixed evidence base. There's a number of negative trials in there, but there's positive trials scattered throughout various models. So I think the take-home message here is that if you have a competently run local specialist personality disorder service, it probably doesn't matter what model they're using, so long as it is delivered consistently and it has a structured and transparent theoretical basis. Right, so we've just got 3 minutes, I think, for any questions.
Thanks, Steve. That was amazing, actually. I wrote a few things down. I put life expectancy, I put an exclamation mark, mentalization, and deprescribing were my take-home things from that perspective today. Thank you. We have some questions. Clozapine query.
Yeah, so clozapine is like the great white hope at the moment. I think lamotrigine was the great hope 5 years ago. There's an RCT being commissioned for clozapine being run in London. If clozapine comes out as useful, clozapine is a difficult drug, obviously. So if clozapine turns out to be the only medication that consistently is useful, then I'm sure we'll start using it in people with severe personality disorder. But you're never going to give it to people with mild or moderate personality disorder unless they're really at high risk. But we'll see. There's been a couple of case series which look quite positive, often in forensic units, but it's difficult to know how much of it is sedation. If you give someone a very sedating antipsychotic and they self-harm less, you've really got to be careful about what is having that impact. We'll see.
Thank you. EMDR and borderline personality disorder.
Yeah, no trials for EMDR. I mean, EMDR is essentially a type of exposure CBT for trauma. So we don't know it'd be with borderline personality disorder that the trials would be done. So I think there's an important trial to be done there.
Thank you. Have you seen an increase in severity of those already diagnosed with borderline personality disorder in your clinics, and a reduction in remission in the last 12 months? If so, what do the patients feel is the cause? Pandemic special.
I know. I mean, people will be aware of the evidence that's emerging around deliberate self-harm over lockdown, which is a bit equivocal, but some of the best trials have seem to be implying there hasn't been a significant increase, but there may have been in younger people. My experience has been people are more distressed, but they're perhaps less likely to go to hospital still, quite a lot of people are still very worried about it. We're also seeing a lot of vaccine hesitancy, which is a worry for me, because it goes with the life expectancy, and people on social media are getting tangled up with this. Not only BME groups actually, but certainly rates of distress have gone up, and we're doing our therapy online. And I think we've recently completed a small piece of work on this, which shows that the therapy online is less effective, because with borderline personality disorder, to contain the distress, the physicality is really helpful for that. So there's a limit to what we can do online. So, but I think in general, yes, I think the levels of distress have gone up.
Thank you. I'm going to ask two more questions, if that's okay. There's a child psychiatrist with us today, and there's been an increase in teenagers requesting a borderline personality diagnosis. What are your thoughts of diagnosing with emerging PD when a young person is still developing their personality?
Yeah, so we had this debate with ICD-11, and ICD-11 doesn't have the 18-year cutoff. So I think emerging PD is the best rubric for under 18s and probably for under 21s, because the studies show that emotionally unstable personality disorder diagnosed at the age of 16, 50% of people by the age of 21 no longer attract the diagnosis, because it has an overlap with some developmental features, impulsivity, promiscuity, and so on, with a developing personality. So I think caution, but for that group of people who I think they do feel like they're becoming more prevalent, for that group of people who clearly have quite severe problems in this area, then I think emergent borderline personality disorder is a useful label, because we know that a group of that, a group of them will not attract the diagnosis in perhaps 5 years' time.
Thank you. With your permission, we may send you a few more questions, but I'd like to end on this one. If a patient no longer meets the criteria for PD, i.e. engage well with therapy, can they be undiagnosed at that stage? And in your experience, does that tend to happen much? Makes the observation, would be good for self-esteem to receive the feedback, I imagine.
Yeah, so we do that. I mean, we would generally wait for 5 years, because PD is a longitudinal diagnosis. You have to have had the symptoms for 5 years, and it can fluctuate according to circumstance. But if someone has emerged from the diagnosis over 5 years, then yes, we would undiagnose, if you like. And I think it's a problem that people don't actually. And given the Zanarini data, which I showed you, people absolutely should. So yes.
Excellent.
Big impact on people's self-esteem and sometimes their job prospects as well.
Absolutely. Thank you so much for such a fascinating presentation. We're going to have to leave it there, but I'm very grateful if you could answer a few of the questions, mostly on deprescribing and prescribing, I must admit, maybe in an email, and we can send out to our delegates if that's okay.
Will do. Thank you very much.
Thank you so much. Right, everybody. So we're moving swiftly on to a presentation by Professor David Baldwin. He's a professor of psychiatry in the Clinical and Experimental Sciences Academic Unit, thank you for such a mouthful, David, of the Faculty of Medicine at the University of Southampton. Amongst other roles, Professor Baldwin is President-elect of the British Association of Psychopharmacology, a medical patron of Anxiety UK, and editor-in-chief of Human Psychopathology. So Prof. Baldwin today will be refreshing our knowledge of the current evidence base regarding the efficacy and tolerability of pharmacological treatment for patients with anxiety disorders, and looking at some of the latest areas of development. So over to you, David.
Well, thank you very much, Mike. Can I just confirm that you can hear me okay?
Absolutely. I'm going to mute myself now.
Thank you very much. And thank you to the organisers of the meeting for the invitation. It's really nice to be part of it. And I also want to thank Steve for his really excellent lecture. I learned so much. It was really fantastic. So here's my declaration of interests. which I won't go through in any detail, although I'm happy to say that I have researched, prescribed and taken antidepressants in the past. So, if we think about anxiety disorders and anxiety symptoms, you might think that we've got a relatively simple task because we have such a broad range of treatments available, pharmacological and psychological interventions with known efficacy and effectiveness in real world situations. And, you know, the principal approaches involve either SSRI treatment or cognitive behavior therapy, CBT, or the combination. Now, this slide here summarizes guidance written for primary care physicians, so that's general practitioners in the United States. And the idea was that everything they needed to know about how to manage patients with anxiety symptoms could be summarized in 2 pages. And they're very broad recommendations, and most of them make a lot of sense. Some of them are perhaps a bit unsubtle and could be a bit more nuanced, and I'll describe why that is the case. So step 1, measure severity of symptoms. So, for example, with the GAD-7, in the way that we measure blood pressure in people with cardiac disease. So it's helpful to know what the severity is at baseline so that then you can actually monitor change over time. Second, lifestyle interventions, things like avoidance of caffeinated drinks, moderate physical exercise, mindfulness-based stress reduction techniques. And if people don't get better, and about 50% of people will get better with these first 2 steps, then think about active approaches to treatment, either medication or CBT or the combination. And the recommendation is that if someone hasn't responded to 2 evidence-based approaches, then they should be referred to secondary care services, which is actually exactly the same as the recommendations produced by NICE and the British Association for Psychopharmacology. Of course, we as psychiatrists see people at the bottom of this, people who actually haven't responded to 2 or more evidence-based treatments. Now, I just wanted to show you this slide. It's a bit complex. The idea has always been that pharmacological and psychological treatments have broadly similar efficacy in acute treatment, but that psychological treatments may be marginally more effective in the long term. So what is the evidence for that? And this comes from a meta-analysis of pooled data from studies of patients with the diagnosis of generalized anxiety disorder, social anxiety disorder or social phobia, and panic disorder, all randomized controlled trials. So the first box, which I've just put up, looks at psychological interventions. At the top is relaxation, and at the bottom is non-face-to-face therapies, which, you know, essentially internet-delivered therapies. And you can see that the confidence intervals overlap. So there's no significant difference between these varying approaches. But in the middle of the box lies the pill placebo. So a placebo given under double-blind conditions within the context of a randomized controlled trial has similar efficacy to psychological interventions. The second box, which I just put up, relates to active pharmacological treatments from SNRIs at the top through to tricyclics at the bottom. Again, you see their confidence intervals all overlap, so there's not much difference between the varying drug approaches. The middle of the 5 bars, which I've just shown, is actually for the combination of CBT and drug, showing here not much evidence that the addition of CBT enhances medication, although studies in this patient group are always slightly complex because people generally haven't responded to a treatment and therefore have a somewhat poorer prognosis. So that's acute treatment. Remember, the argument is always that psychological treatments may be better in the long term in terms of keeping people well. So first of all, let's think about medication. How good is medication in keeping people well? How can it prevent relapse? So this is a BMJ published meta-analysis looking at not just the 3 anxiety disorders I mentioned earlier, but also OCD and PTSD. And in these studies, people are treated with a medication until they're in remission usually, or certainly have responded. So they've had a 50% reduction in symptom severity, and then randomized to either continue with that treatment or to be switched over to placebo under double-blind conditions and followed up sometimes for 6 months, sometimes even up to 2 years. That's the nature of the study, the relapse prevention trial. And in the forest plot, in the figure on the bottom right-hand side, remember you always look at the bottom diamond. I put the red circle around it. It's clearly to one side of the vertical line. What this means in this case is that one intervention is significantly better than another. And in this case, it's staying on treatment is better than being switched over to placebo. So if you were switched to placebo, the chance of relapse is 36%. If you stayed on active medication, the chance of relapse was 16%. Also, you were, if you remained on active treatment, you would remain well for longer to a significant degree. Now, what the authors did was very clever. They then did sensitivity analyses looking at various subgroups. So an obvious one is, do the anxiety disorders differ in terms of the advantage of medication over placebo? And the answer was no, it made no difference at all. Secondly, did it matter for how long you had been well before you entered the randomized controlled trial? And that also made no difference. Then the length of the double-blind study, I mentioned some were 6 months, some were up to 2 years. Did that make any difference in terms of the advantage of medication over placebo? Was there any evidence that that advantage was lost with the passage of time? And the answer was no. And then a couple more subgroup analyses. One was whether or not people continued with a psychological intervention or not. And the provision of a psychological intervention did not obscure the drug placebo difference, nor did the mode of stopping treatment. Some studies, they had a very rapid discontinuation. Some they were very slowly tapered, but that didn't make any difference in terms of the advantage of medication over placebo. So we know that the drugs work, and we know that as long as you take them, there is an advantage for being on them compared to being switched over to placebo. So how does that compare to psychological interventions? And the answer is there's still a lot of uncertainty about this. We haven't got many large randomized controlled trials of long-term treatment given under double-blind conditions. So this figure here is again looking at just GAD, panic disorder, and social anxiety disorder. So the patients have responded to acute treatment and are then followed up for up to 2 years. Now there's a whole range of studies. Some are for medication, some are for CBT, some are for other forms of psychological intervention. And what the authors were looking at is the effect size. So the effect size at the end of acute treatment, and then following that over time to see if there was any loss of effect over up to 2 years. And the answer actually was no. There was very little loss of effect. Now you have to understand that this is within the context of a randomized controlled trial in which people are being followed up. So it's actually slightly different to normal clinical practice. But essentially, if you had responded to acute treatment and were taking part in a trial and followed up for 2 years, then the chances are you would remain well, whatever it was that had got you well. But there were very few comparisons of drug versus psychological treatment. Overall, actually, marginally, it looks as if being on a medication, the top blue line, sorry, being on a psychological treatment, which are the top blue lines here, are somewhat better than being on a medication. You had more relapses in the first 4 months in people on medication than was the case in people who were undergoing psychological treatment. So what I'm going to do now is take you through disorders in turn. Mike mentioned the BAP. The BAP produces guidance on most psychiatric conditions. The guidance on anxiety disorders were published in 2014, so 7 years old, due to be reviewed fairly soon. What I've done here is summarize the guidance relating to GAD. I'll talk through various aspects of it in more detail. But you'll notice that some is in dark print and some is in a grey font. And the grey font represents things which I think are likely to change in the next set of guidance. So if you're going to use pharmacological treatment in GAD, an SSRI is the first line pharmacological treatment, and SNRI or pregabalin is used if an SSRI is unsuitable. You notice that pregabalin is in grey now, and that's because of increasing concern regarding some aspects of pregabalin, which means that it's probably going to be recommended somewhat lower down in the next set of guidance. In terms of psychological interventions, both CBT and applied relaxation are very effective treatments, shown in meta-analyses, broadly similar in their efficacy. There's very little evidence for a dose-response relationship with SSRIs, more of that in a minute, but there is evidence for a dose-response relationship with pregabalin. So if you are prescribing pregabalin to a patient, usually as a third-line treatment, it is worth pushing the dose if you can. The combination of CBT and drug treatment should be reserved when people haven't responded to either, given as monotherapy. And you'll notice that I mentioned benzodiazepines. The BAP believes that there is still a role for benzodiazepines in a small group of patients who have chronic, severe, distressing, disabling symptoms which haven't responded to a succession of pharmacological and psychological treatments. And then we recommended 18 months of continuation treatment on the basis of longitudinal studies in patients with GAD and also relapse prevention trials. And then right at the bottom, you notice that we say, once the continuation treatment is concluded, reduce the dosage steadily. Now, this was what's called a level D recommendation because there was very little evidence to support it, but it was a kind of a consensus view. We felt that it was reasonable to reduce the dosage steadily over 3 months, partly to avoid any discontinuation symptoms, but also just to kind of keep an eye on people and to see if they show any signs of their symptoms returning. So obviously there's been a lot of interest in discontinuation or withdrawal symptoms with antidepressants in recent years. Do they happen? Yes, they can. How do we know that? Well, we know that from randomized placebo-controlled trials in which treatment is stopped either abruptly or tapered We know that about 10% of people who stop placebo experience discontinuation symptoms, and in randomized controlled trials, about 30% of people who stop antidepressants will experience discontinuation or withdrawal symptoms. The Royal College has produced guidance on this, and the link to that is on the college website. It's number 5 here at the bottom of this slide. If you actually just type in RC Psych stopping antidepressants, you're taken to this. It's guidance for patients, but actually there is an appendix at the end which kind of illustrates how this might be done in clinical practice. So a little bit about dose-response relationships in GAD. Remember, I said that there was no evidence for a dose-response relationship with SSRIs. That's actually a consistent finding with many drugs. This is an example. It's the study that I led of acute treatment of patients with GAD with 3 different doses of escitalopram. Paroxetine was included for assay sensitivity. And if you look here at the findings at week 12 of double-blind treatment, you got 5, 10, and 20 milligrams of escitalopram. This is looking at the proportion of people who are in remission, and there's actually very little difference between the 3 differing doses. So no clear advantage that higher doses are better than lower doses. So I mentioned the guidance from the BAP was published in 2014. Obviously, data is accumulating. Will this lead to changes in the recommendations? Yes, it will, to some extent. We always tend to look at meta-analyses. So these have been done for individual drugs, but also for certain drug classes. So the meta-analyses indicate that duloxetine, quetiapine, pregabalin, and venlafaxine are all effective. Also, the drug vilazodone, not available. It's an SSRI mixed with a 5-HT1A partial agonist, available in other countries, also works in GAD. The evidence for vortioxetine in acute treatment in GAD is inconsistent. A bit more about comparisons between differing classes in the next slide. When comparing medication to psychological treatments, effect sizes were larger with psychological interventions than with pharmacological, but the trials differ very markedly in design. Many of the psychological intervention studies compare active psychological treatment to waiting list control, whereas the medications compare it to a pill placebo, so you can't really compare them directly. Now, differing drug classes. Sorry about the small print here. You don't really need to concern yourself with the details, but essentially what it's looking at is acute treatment of patients with GAD with either benzodiazepines in green, SNRIs in blue, or SSRIs in red. And right at the bottom, you might just see a kind of mauve colored square, and that's the overall effect size, which is 0.37. That's moderate effect size. The effect size for benzodiazepines was somewhat higher at 0.5, and the effect size for SSRIs and SNRIs was somewhat lower than the average. So you could argue that actually, in terms of effect size in acute treatment, the optimal treatment is a benzodiazepine. But of course, it's not just about efficacy, it's also about tolerability and safety and potential risks. And that's why, even though the evidence for efficacy is strong, benzodiazepines still tend to be reserved for patients that haven't responded to other approaches. Pregabalin. Now, pregabalin is something of a disappointment in many respects. There's a wealth of data on pregabalin in patients with GAD, and we know that it is effective in short-term treatment and also relapse prevention. So this is a pooled analysis that I undertook some 6 years ago, looking at the effectiveness of pregabalin in GAD. And regardless of things like the presence of coexisting depression or very marked insomnia or very high symptom severity, pregabalin was always superior to placebo and reasonably well tolerated, the most common side effects being dizziness and somnolence, which were about 3 times more common with pregabalin than with placebo. So, you know, it works. But of course, we're increasingly aware of potential problems with pregabalin. It's very rarely abused by patients with GAD or other anxiety disorders, very rare indeed, but it is abused in other settings. The drug has street value in Southampton. It tends to be used by polysubstance abusers and also in forensic settings. And of course, the drug is now a controlled drug. So prescriptions of it are now more closely regulated. You can't have automatic electronic prescriptions. They need to be renewed regularly. And this is an attempt to limit the availability of pregabalin in the population. But thankfully, patients with GAD can still have access to it and benefit from it in many cases. So I've mentioned benzodiazepines. There's a lot of interest about benzodiazepines. Again, I don't know how many of you are assiduous readers of the Yellow Journal, but the editorial, the leading editorial in the last month was on benzodiazepines, asking really the question of have we got it wrong? Have we become overcautious about use of benzodiazepines? The authors of that make quite a strong case to say that we have. It'll be interesting to see what the correspondence is following publication of that editorial. Within the BAP, we feel that there is still a role for benzodiazepines in, as I mentioned earlier on, patients with chronic, severe, distressing, disabling symptoms which haven't responded to other approaches. And in some of those patients, then there may be a role for long-term treatment. But if you are going along that course, then you should do whatever you can to help patients come off the benzodiazepines when they feel ready. So how can you do that? A variety of approaches have been suggested in terms of helping people stop benzodiazepines, and the evidence is mixed. The general approach is gradual withdrawal at the patient's own rate, and that seems to be most effective when coupled with fairly simple psychological interventions based on along the lines of motivational interviewing. So now, panic disorder. Now, you'll remember from GAD that when I showed the summary, there was a lot of grey print. There's no grey print here. This is all the darker font. Have I forgotten to add in the new data? No, I haven't. It's actually that there's very little new evidence to make you change the guidance. I'll quickly run through what the guidance has been. Use an SSRI as first-line treatment or CBT as a first-line psychological treatment. There is still some scope for considering a benzodiazepine for the initial weeks whilst waiting for an SSRI to become available in terms of its onset of effect. But actually, although you might get a greater reduction in symptom severity at 2 weeks, there's very little evidence for the advantage of combination treatment. And therefore, we actually felt that we shouldn't use them routinely in combination whilst waiting for an SSRI to begin to work. There is evidence of a dose-response relationship with SSRIs in panic disorder, as well as in OCD. That's obviously different to the situation in GAD. And combination approaches are optimal. There's good evidence to indicate that the combination approach is better than monotherapy with either medication or talking treatment. So that was the guidance from 2014. Obviously, new meta-analyses have been published. There is a limited amount of new data. The meta-analyses looking at psychological treatments argue that CBT is superior to other psychological interventions in terms of reducing symptoms, like, reducing the number of panic attacks or reducing the degree of agoraphobic avoidance. Although, interestingly, psychodynamic psychotherapy comes out quite well in these meta-analyses. In terms of number needed to benefit, benzodiazepines have a lower number than antidepressants, which suggests that maybe the benzodiazepine is somewhat more effective than an antidepressant, although there have been very few head-to-head trials. You occasionally hear arguments that actually the only reason antidepressants work in panic disorder is because people interpret the side effects of treatment. They feel that I'm experiencing an active medication and that it's all due to kind of anticipation and kind of placebo effect. That's rubbish. There's been looked at in a fair bit of detail, looking at the experience of side effects and the degree of efficacy, and there is no relationship between the two. This is unpublished data, not yet fully peer-reviewed, so you need to be a bit cautious. It's one of those network meta-analyses where you compare all the treatments together, very large numbers of patients, over 11,000 here. 13 of 19 treatments were superior to placebo. Rather little difference between the treatments. Actually, the treatment which came out as most effective was CBT combined with a drug. CBT combined with a drug was better than other interventions. So the combination of CBT with medication was better than CBT alone or medication alone. But CBT on its own was not superior to any medication alone. Okay, now moving on to social anxiety disorder, social phobia. Again, very little grey print. What I want to do when thinking about social phobia is to remind you about MAOIs, or reversible inhibitors of monoamine oxidase, REMA. We recommended them as a second-line pharmacological treatment when people haven't responded to an SSRI. Why is that? Well, this is the reason. So this is one of those network meta-analyses. The cat's cradle on the left shows all the differing comparisons performed between differing treatment approaches, and the figure on the right is looking at effect sizes. So nice guidance for social anxiety disorder, recommended either CBT or an SSRI or an SNRI on the basis of effect sizes. And actually, that's kind of curious in a way, because the effect sizes were greatest for MAOIs and benzodiazepines. Of course, they're harder to prescribe, possibly more tolerability concerns with them. The number of studies is smaller. The number of people that take part in those studies is also smaller. So they were cautious and therefore actually didn't recommend them as first-line treatments. So what do you do when someone hasn't responded to an SSRI if you're not going to prescribe an MAOI? I like this study very much because it's a very kind of sensible comparison of either remaining on the SSRI or being switched over to venlafaxine, or staying on the SSRI, in this case sertraline, but with the addition of a benzodiazepine clonazepam. So people who hadn't responded to sertraline after 10 weeks, given at flexible doses, took part in the trial, followed up over 12 weeks. And actually the people that did best in terms of reduction in symptom severity was actually those on sertraline plus clonazepam. So the authors argued that actually the addition of a benzodiazepine is a superior second-line approach than switching to venlafaxine. I mentioned combination treatments in panic disorder. There's clear advantage for combination approaches. For social phobia, the evidence is not quite consistent. The most recent meta-analysis indicates that the combination treatment is probably optimal in partial responders. So if you're a partial responder to a medication, then the addition of CBT is better than continuing with the medication, or vice versa. There have been a couple of trials published since then, which have had mixed findings. So in one, paroxetine did not enhance cognitive therapy, but in another, sertraline did enhance the efficacy of group psychodynamic psychotherapy. So there's probably a need for another meta-analysis. Separation anxiety disorder is included within the DSM-5 as a diagnosable anxiety disorder in adults. Remember that about 1/3 of people with separation anxiety disorder develop it after the age of 18. Very little evidence to guide practice, unfortunately. You could look at the results from children and think that studies showing efficacy in children might be applicable to adults, though that may not be the case. There's only one placebo-controlled trial of medication in separation anxiety disorder. It's a small proof of principle trial with vilazodone, which I mentioned earlier on, but that was superior to placebo. Now, PTSD, post-traumatic stress disorder, since the guidance was published in 2014, there's been quite a lot of interest in PTSD. The first thing that happened was a trial examining flexible doses of quetiapine over a very broad dose range of 50 to 800 milligrams per day. But quetiapine does work in PTSD. It's not licensed for the treatment of PTSD, but it does actually work as a monotherapy. Trauma-focused CBT is probably the optimal psychological treatment, although EMDR is also effective and is increasingly adopted in mental health services. Obviously, the name post-traumatic stress disorder suggests the opportunity for intervention after trauma. You know, someone experiences a trauma and you could do something and see whether or not that reduces the incidence of PTSD at follow-up. There have been quite a few such studies looking at pharmacological and psychological treatments. We, in our guidance, said that we should avoid routine debriefing after trauma, as that does not work, and that's still the case. Of all the medications shown to reduce the incidence of PTSD, it's a rather curious finding that the drug that does best is hydrocortisone. Now, of course, we're not going to go around prescribing hydrocortisone to all people that have experienced trauma. The number of studies is small. The number of people taking part in those studies is limited, and they are actually medically ill patients, usually in ICU settings, who are given a steroid and seem to have a reduced incidence of PTSD. But it suggests that there is scope for studies examining steroid treatment after trauma to see whether or not it can reduce PTSD in more representative populations. Oddly, meta-analyses have kind of produced differing findings as more and more unpublished data are secured and examined. We recommended fluoxetine, paroxetine, and venlafaxine. This is still recommended after the meta-analysis from Jonathan Bisson's group, looking at SSRIs and SNRIs. Andrea Cipriani produced a very intriguing paper looking at treatments for PTSD, and more of that on the next slide. Prazosin, the antihypertensive prazosin, has been found effective in reducing nightmares and hyperarousal and sleep disturbance. The anticonvulsant topiramate can reduce hyperarousal symptoms, and MDMA, ecstasy, has been found effective in a treatment-resistant group of patients. This is the data relating to SSRIs or SNRIs. Remember, always look at the bottom. Does it lie to one side of the vertical line? Yes, it does. This is for SSRIs. So as a class, SSRIs were superior to placebo, although when you look at the various trials all above, most of these studies actually cross the vertical line in terms of their confidence interval, so actually don't find evidence that the drug works. So the signal is not strong for SSRIs. This is the Cipriani meta-analysis, and is, as I said, interesting because the drug which actually comes out best, would you believe it, is phenelzine, the MAOI phenelzine. It was the drug that had the highest probability of being the most effective, and also did rather well in terms of tolerability. And the authors wrote the following: it's probably not robust enough to suggest phenelzine as a drug of choice. I think that's correct, but the findings reinforce the view that phenelzine should be prioritized in future trials, which I think is reasonable. Of course, you know, we've had problems in the last year in terms of gaining adequate access to phenelzine. It's become quite hard to access for many patients, but it does suggest that a drug with that mechanism of action is worth studying in patients with PTSD. Of course, many of us find that SSRI or SNRI treatment is effective, but only partially effective, and then wonder what to do next. The addition of mirtazapine is a perfectly reasonable thing to do. There's placebo-controlled evidence to show that the combination of mirtazapine with sertraline is better than sertraline alone. So always worth considering the addition of mirtazapine. But it also depends on the symptoms. So if someone's got really very marked sleep disturbance, even after SSRI treatment, then actually cognitive behavior therapy for insomnia has been studied surprisingly frequently. There are 11 RCTs of it, of CBTI in patients with post-traumatic stress disorder, and it works. It helps people fall asleep quicker and stay asleep longer and have fewer awakenings during the course of the night. So finally, OCD. The principles about OCD in terms of pharmacological treatment is go for an SSRI as first-line treatment. Always remember clomipramine in people that don't respond to SSRIs, but push the dose wherever possible, push the dose. So for example, with fluoxetine, you might need 60 or 80 milligrams per day. Always push the dose wherever possible if people are tolerating the lower dose, because there's good evidence for a dose-response relationship. The exposure-based psychological interventions have the edge. This is the guidance, well, the analysis that led to NICE guidance, indicating that exposure-based therapies are really the optimal psychological intervention. But of course, many people don't respond to high-dose SSRI in combination with CBT or behavior therapy, and then you're left wondering what to do next. And the best evidence is still the addition of an antipsychotic. All antipsychotics have been studied, or commonly prescribed antipsychotics have been studied. The evidence is strongest for risperidone and aripiprazole. This is work that we did in Southampton, just looking at combination treatment. And it was an interesting finding. Actually, the people who had combination treatment at 1 year did less well than people on sertraline alone or CBT alone. And that's a curious finding. And sertraline did best. And that's probably because the dosage was higher. In combination treatment, there was a tendency to reduce the dosage of sertraline. So the message is, don't do that. Although you might think that people are having 2 evidence-based treatments and therefore you can reduce the dosage of an SSRI, don't do that because you'll just get a loss of efficacy. So maintain the dose that gets people well. This is the data for antipsychotic augmentation. As I said, the evidence is strongest for risperidone and aripiprazole. Of course, aripiprazole is slightly more likely than others to cause this kind of nervousness and akathisia. So risperidone is a reasonable approach. Olanzapine, quetiapine also can be useful. A little bit of a sidestep into cannabinoids and psychedelics. Obviously, there's a lot of interest in this at the moment. It's been argued that psilocybin from the magic mushroom, that psilocybin might be effective in OCD. We don't know whether or not it is. There's just a very small case series, but there is a randomized controlled trial underway to see if psilocybin might work. Cannabinoid treatments are being advocated by some as treatments for patients with anxiety disorders, PTSD and OCD, but again, the evidence is very limited. Certainly worth exploring within the context of randomized controlled trials, but at the moment we can't recommend cannabinoid-based medicines for patients with these conditions. Finally, a little bit about what we're doing in Southampton. We're exploring the GABA-A receptor in a little bit of detail. You'll remember that the GABA-A has 5 components, the subunits, which mediate different properties of benzodiazepines and GABA itself. The alpha-1 unit is involved in sedation, the alpha-2 and alpha-3 in anxiolysis, alpha-5 in memory disturbance. The idea is that we might be able to develop a ligand that is effective against, that binds to alpha-2 and alpha-3, but not the other subunits. So you can have anxiolysis without sedation or memory problems. This work is being led by Professor Attack in Cardiff. So we're exploring this through the context of our model of GAD, which is based on carbon dioxide inhalation. What happens with carbon dioxide inhalation is you get a respiratory acidosis, and this generates anxiety symptoms through the amygdala because of chemosensors in the amygdala. The most important one is called the acid sensing ion channel ASIC1A. And there are some interesting drugs which bind to ASIC1A receptors, including ibuprofen and amiloride. So we've been exploring these very familiar old drugs as potential anxiolytics, and actually they do in this model have anxiolytic properties. So I won't show that. And the other thing to remember is there's a lot of interest in anti-inflammatory treatments as potential treatments for patients with depression, but also in anxiety disorders. The lady here is Dr. Rewa Ho, again in Southampton. She is leading our work in psychoneuroimmunology. And what she's shown in GAD is that there's an excess of pro-inflammatory cytokines and a deficiency of anti-inflammatory cytokines, and that effective treatment alters this so that the profile of cytokines moves towards that in the non-anxious patient. Also, the degree of change in the inflammatory profile correlates with the degree in reduction in symptom severity. So maybe there'll be anti-inflammatory treatments for anxiety disorders in the future. And to conclude, we need many more studies in comorbid patients, more studies in patients with panic disorder, a lot of interest in older drugs and thinking about their targets and whether or not we can develop drugs which have the same mechanism of action, but some of the fewer of the problems of the older drugs. There is scope for the potential repurposing of other drugs based on these findings in experimental medicine models. And we need to be very cautious when considering controlled or psychedelic or cannabinoid-based medicines at the moment, but watch this space because there's a lot of research in that area. So at that point, I will end. Thank you very much.
Thank you so much, David. Such a wealth of information there. I'm aware that we're going into a break, but I'd really like to take the opportunity to just blast you with a few questions, if that's all right, Prof. There's one about buspirone. Yes. Are we convinced, basically, of its efficacy in any modality?
Well, I mean, buspirone does work in acute treatment in GAD. There have been actually quite a few trials to show that. It's not effective in other anxiety disorders. It is worth considering. We recommend it before benzodiazepines in GAD. It's worth trying. Remember that a lot of people feel quite sick and dizzy on it. So start low, go slow. But if there's no benefit at 12 weeks, it's not going to work. So stop it and move on to something else.
Thank you. There's a question on postnatal periods for patients with OCD symptoms, particularly if they're unable to participate meaningful in CBT due to childcare, sleep deprivation. Any thoughts on that?
Yeah, thank you. I mean, actually, it's very interesting is that OCD is actually often emerges in the postpartum period. You can use medications. Obviously, then there's the concern about breastfeeding. The SSRIs do cross into breast milk to some degree. They're not sedating of the child. It might be slightly sedating of the mother. So the mother might not wake up to feed the child, but the children themselves do fine.
Thank you. I have a question from one of our panelists. Any view on quetiapine or other antipsychotics can be used in other anxiety disorders other than PTSD and OCD if other treatments haven't helped?
Yeah, well, quetiapine certainly works in GAD. There's good evidence in acute treatment and relapse prevention, and is licensed in many countries around the world. It's not licensed in the UK, but it is licensed. So there's good evidence to support its use. It's, as I said, can be used in OCD. It can be used on its own in PTSD. I'm not aware of trials with quetiapine in social phobia or panic disorder.
Thank you. I have a comment. Interesting that in the olden days, raised temperament was called being inflamed, and scientists are now trying anti-inflammatories for anxiety. Is there a psychosomatic overlap?
Yeah, I agree. It is interesting.
Yeah. And I have one question. Transcranial magnetic stimulation.
Yes.
That I'm hearing things about OCD. Is that
Yes.
something that I'm hearing right?
Yes. Yeah. There are trials. I mean, there trials have been done. There is a trial, a large one going on of TMS in OCD. ECT does not work in OCD, but TMS may do. So kind of watch this space. Yeah.
Thank you. And what group of benzodiazepines is effective in specific anxiety disorder?
Yeah. Well, in general terms, given that anxiety disorders are, long-term conditions, and that people present only after many months and sometimes many years, you don't need to have a very rapid reduction in anxiety. It's not like the situation in I don't know, in mania or something where you need really rapid tranquilization. So you can actually start with long-acting benzodiazepines. So diazepam rather than lorazepam, or even clonazepam, which can even be prescribed once a day. So go for the longer acting benzodiazepines.
Thank you so much. There are other questions on clomipramine, but I'm going to park those and send them to you separately. So yes. Just to say thank you so much, Professor Baldwin, much appreciated. A wealth of information there, which will take some time to digest, but when we do, wow, it's going to be amazing. So thank you so much.
Very much.
So on that note, we're going to take a 10-minute break and reorg at 3 o'clock for Dr. Juraina's presentation on treatment-resistant depression. I look forward to seeing you all there. Thank you. Hello, it's 3 o'clock, so we'll get going. After two fantastic presentations, we have another great presentation by Dr. Juraina. Dr. Juraina is a consultant psychiatrist at South London and Maudsley Trust, currently the lead consultant for the Maudsley Advanced Treatment Service for treatment-resistant depression and bipolar disorder. He has published extensively, and we are so fortunate to be able to tap into his expertise today. So Dr. Juraina is going to present a long-needed reframing, in my view, of the concept of treatment-resistant depression and its treatment. So over to you. Thank you very much, Doctor.
Thank you very much for your kind introduction, Mike. Just confirming you can hear me well. Yeah?
Yes, we can.
Thank you very much. So as you said, I am a clinical senior lecturer at the King's College London, and since 2019 leading the Maudsley Advanced Treatment Service for treatment-resistant depression and treatment-resistant bipolar that is part of the National Affective Service. So Sophia, the next, please. So just my disclosures, you see, most of my grants come from foundations, and I am a board and speaker for some drug companies, but my paid position, as said, is King's College London and NHS. Next, please. So you have great presentations this afternoon. You know, I really attend both talks, and depression is the most burdensome of all medical disorders, as you know. And most of the time are comorbidity with personality disorders and anxiety disorders. But I think I'm showing you here on the left side of the screen a sad pizza. You know, it's a sad pizza, it's not a happy pizza, because you can see that almost 50% of the patients with depression will have recurrent episodes, and several of them will be unremitted, will never reach full functional recovery, and they will keep residual symptoms, and most of the time they will have very severe relapse and chronicity. We know several things about depression. We know that major depressive disorder is a spectrum of different disorders together. But anyway, we know also that female have higher vulnerability comparing with male, 2 to 1. we have a risk of more severe depressive course if they start earlier in younger people. My colleague Avshalom Kaspi at IOP developed several studies that most of you already know about polymorphism of serotonin transporter gene that can predict worst outcome, suicide ideation, and combined with early life stressful events can increase the risk of chronicity and treatment resistance. If a patient have a history of alcohol or drug abuse, definitely this is impact in the outcome as well. And something that possibly was mentioned before by David, prior panic attack definitely is something related to a worst outcome. So the risk of recurrence is really impacting each episode. And so that's the reason that you should have an early diagnosis and an early effective treatment. Next, Sophia, please. So when I moved to this country, I sent a letter, actually I email at that time already, to Professor Eugene Paco in Cambridge. And I said, Professor Paco, I'm fascinated by your study that you published related to residual symptoms in the course of depressive episode. So in this paper that he published in the 90s, Professor Paco demonstrated that patients with residual symptoms will have a really increased risk of relapsing. 3 in 4 patients with residual symptoms, and most of the time these patients will have severe depressive episode that they can possibly improve, but they keep some vegetative symptoms like problems in sleep or cognitive impair, and this is will be like a snowball, something to start a new relapse. So if you have a patient without residual symptoms, and Professor Paco followed these patients for more than a year, 15 months, you can see that just 1 in 4 will have relapse in this period. The next, please. So I work a little bit in Maastricht, and I have the possibility to know better the studies of Professor Van Praag. And Professor Van Praag, I think, was one of the pioneers to describe the impact of stressful situations. And so I think this is good that this talk could be after the great talk from David, because there is a relation between anxiety, stress, and several depressive episodes. So if a patient becomes very chronic with several episodes, you can see that this is a risk for depression. Professor Bob Post in US also demonstrated this in another point of view, studying more bipolar patients, bipolar depression, that he can demonstrate in this diagram here on the bottom of the slide that you have big arrows in the beginning. You see precipitant episodes, and then these arrows will decrease the size, but the sensitivity or even the precipitant episodes decrease, but the mood episodes increase, so they start to have spontaneous episodes without stressors. And this is the kindling model that he developed, and he's really studying a lot in US. Nowadays, even with old age, he's one of the main researchers in the field for the impact of early age stressful events to start very severe depressive and bipolar depressive episodes. The next one, please. So there is numerous pathways and biological process to consider for patients with major depressive disorders. Actually, one of the more recent and impacting in the field of clinical practice is the glutamatergic pathway, because after several years, we have new medications that are acting in the glutamatergic, opioids as well, but most of our current medication is just working at monoamine serotonergic, noradrenergic, and dopaminergic pathways. And we have also several studies that demonstrate the impact of stress, mainly early life stress in HPA axis, and how disease can change this course and the severity of depression in adults. Like glutamate, GABA is another amino acid, excitatory amino acid that have been studied for several new approaches that are coming. So I mentioned endogenous opioid and also some cholinergic and adrenergic balance that is coming as well. So there's new possibilities that are coming now after, let's say, since the beginning of the monoamine oxidase inhibitors in the 50s, or the first antidepressants like imipramine. We have new mechanism of actions coming. This is very stimulating for clinicians and for researchers. The possible biological process is something that have been studying for some time. And so we can also integrate some advances in genetic, epigenetic. This is something that can impact really in the future of some treatment. And as I said, neuroendocrine, autonomic, and also immune dysregulation. You know, you can consider depression as an inflammatory disorder as well. So this is impacting neurogenesis, in neuronal plasticity, and now all the possible impact in these mechanism or pathways for biological process of depression. The next, please. And so we have been studying at IOP for a long time with Tony Clear, Kamini Parianti, Alan Young, relation between these very severe and recurrent depressive episodes. That is like a new stressful event, you know, that can impact in the hypothalamus pituitary adrenal axis, and then we impact in the immune system. Because just give a click, Sophia, please. You can see this is another diagram here that we published more recently with Alan, that you can see not only the HPA axis, but also other structures are involved here. Hippocampus, that you know is quite important for memory, amygdala for emotional memory, and the GABAergic, like amino acid, excitatory amino acid, you can put here also glutamatergic, have an impact in this stress axis, that is HPA axis, that will release cortisol and other hormones that are quite important, and then you have a negative feedback. And so normal people will have a negative feedback after stressful events, but patients with depression will not have this negative feedback, that possibly the two receptors here, the glucocorticoid receptor and mineralocorticoid receptor, are not really working well. But I think for clinical practice, one of the most important things that we have here, that is the connection of the serotonergic neurons and the noradrenergic neurons in half nucleus and locus coeruleus, that can impact in the HPA axis, and then could possibly decrease the effect of stressful events or stressful situations like SSRIs can do, well described recently, or maybe can put a little bit of fuel gas in this fire, like if you put a noradrenergic input, you know, so you can change the impact of these in glucocorticoid receptors. So this is the main idea, possibly a whole message, that you have this connection between the monoaminergic and also amino acids excitatories like GABA and glutamate with the HPA axis, and then HPA axis will impact the inflammatory markers. So everything is connected, and everything is impaired in patients with depression. The next, please, Sophia. And so this diagram here is a paper that David Nutt published some time ago, and David put the things in a very clear way. I think he mentioned about two didactic types of depression here. Of course, this is just a simplification, but we have patients that have a decreased positive effect, you know. So this patient will have mainly the possibility to decrease mood, decrease happiness, decrease energy, decrease interest, decrease pleasure, and also this is possibly is an impair in noradrenergic and dopaminergic system, you know. And so if you are using some medication, an approach that can possibly improve the neuroepinephrine and noradrenergic circuits or dopaminergic, you can possibly increase this positive effect like self-confidence, alertness, enthusiasm. On the other hand, you have in these patients maybe together both the increase negative effect, you know, patients increase guilty, increase fear, increase anxiety, increase hostility, increase irritability, increase loneliness. So this increase of negative effect really impact mainly in the norepinephrine and also serotonergic neurons. So you need to balance between these two when you have some residual symptoms. The next one, Sophie, please. I hope you all can hear better now. And so
Absolutely, Mario.
thank you for your feedback, Mike. Roger McIntyre from Toronto University developed a very nice model that is very useful for clinical practice. That is a correlation between mood disorders and metabolic disorders. Possibly they share common endophenotypes. And usually you can see several patients with very severe mood disorders. Alan Young and I just wrote a book chapter about mood disorders and metabolic syndrome and diabetes. And so that's very common in clinical practice. Obesity over 8 as well. And of course, if the patient have this kind of metabolic syndrome, will impact in the neurodegeneration, in the glia degeneration. I think this was just mentioned in this session. So this is where also you have an important impact in cognitive deficits. So you can see that if you increase the metabolic syndrome in the over 8, this is impacting hippocampus and other important cognitive circuits that will increase the cognitive deficit that you can see so often in patients with depression. Sophie, the next, please. So the main point about our topic today, treatment-resistant depression, is that they have severe consequences for not only for cognition, for metabolic syndrome, but also for costings as well. And so you have patients with more comorbidities, and so cardiovascular problems are quite often as well. The rate of hospitalization is really increasing patients with this subtype of depression, and they stay longer in the hospital. And the main point I think is really impacting nowadays in these difficult times is the increasing suicide rate. You know, as said in the beginning, I'm running the service with patients from South London with treatment-resistant depression, and definitely we are receiving several referrals of patients that are moderate depression and then become very severe. And now they are with suicide ideation and suicide attempts. So this is increased significantly in this time, and is something that is almost pathognomonic for these kind of patients. The next, please. So one of the points is related to the concept of treatment-resistant depression. You know, I think all psychiatry that is working with patients with severe depressive episode need to read this classic paper about the STAR-D. You know, STAR-D developed this naturalistic study that you can see that the patients are considered treatment resistant if they fail to 2 different trials in the right time, in the right dose. You know, and one of the main findings of this important study from John Rush is that fewer than 15% who failed to 2 different antidepressants were able to reach remission in the next steps that they are proposing. You know, so those that do reach remission, you can say that between 30 and almost 70% do not sustain this remission. They have relapse. So this is a big problem. You know, you can see that it will be difficult for patients to reach remission without symptoms. It will be difficult for patients to sustain that remission. So we can classify really depression as a very chronic and resistant mental disorders, not a mild like used to be considered in the last century. So the next slide, please. So if you think about based on the STAR-D, you have these two main ideas that I try to summarize in this slide here. The failure to respond very often, the failure to retain or sustain the response. This current definition, and this is another discussion in the literature, that you possibly will need to have a better concept, because treatment-resistant depression is the history of treatment, but it's not a diagnosis. And it's becoming more often, and is important to refine this concept, because the current definition of TRD focus exclusively on the acute treatment trial and the failures that happens without considering if they have residual symptoms, relapse, complete remission. So it failed to capture a very large proportion of oscillations in this course. Working at the Bethlehem Royal Hospital, let's say in the beginning of this century, 2003 to 2008, 10, we can say that our patients in the inpatient ward had most of them a history of 20 years of severe depressive episode. But of course, in this history, you could not capture most of these oscillations and these relapse that we can see in the course of very severe and treatment-resistant depressive episodes. The following one, please. So just forgive 1 or 2 clicks more, Sophie, por favor. You can see here the vulnerability here. The vulnerability of depression is quite related to the genetic background. So there is an impact of genetics, but you can see this girl on the bottom. You can see that she's suffering from emotional abuse. So the combination of nature and nurture will have an impact in adulthood. So the lady on the top is stressed with several situations in her work, maybe a relationship. If a patient have a history of drug abuse or any kind of physical illness, or these times that you are being impacted by the COVID. So this will in vulnerable people that have a history of early life stressful situation, increase the severity of depressive episode, the impulsivity that can increase even anxiety symptoms, isolation, and suicide attempts. Next, please. So several studies have demonstrated these, the impact of adverse life events on treatment-resistant depression. So early life stress like abuse, neglect, have a significant impact on patient response to antidepressant treatment. So when I was a junior doctor, usually my professor said to me, Mario, please, it's important to assess the suicide ideation, the suicide plans, and even previous suicide attempts. And definitely I try to teach my junior doctors today the importance to assess the history of early life stress in patients with severe depressive episode or even a history of treatment-resistant depression. Because patients who experience trauma were significantly less likely to respond, as you can see in both graphics here. Responders are really lower comparing with patients with no abuse if they suffer abuse. And even reach remission is even lower if the patient have a history of abuse. Could be sexual abuse, physical abuse, emotional abuse, both can impact in the treatment outcome, and subtypes of neglect can also impact in these as adverse life events. Next, please. I think all of you know this guy here, and he suffered from emotional abuse. If you can hear his history, that's a very important actor with skills to move from comedy to tragedy. And this is a picture a day before he's committed suicide. If you know his history with several comorbidities, with bipolar depression, neurological problems in the end, as you can see, Parkinson and others. But the main point that he started with this early life stressful situation, history of emotional abuse, drug abuse, and then develop this very severe course that leads him to suicide. The woman in the picture could not really detect these or diagnose these because she's not in the field, but we should try to predict that this guy will have a high risk of suicide if you know his history. Next, please. So related to this, you have the impact of comorbidities. It's already mentioned about anxiety. The comorbidity with depression is really higher in patients with treatment-resistant depression. I mentioned in the beginning about panic disorders, the real impact of panic disorders, social phobia. Melancholic subtype of depression is higher as well, and patients with a history of suicide behavior can have an impact as well. The severity, if you measure the severity of depressive episode with any scale like Montgomery, Asberg, or Hamilton, or Beck, you can see that this is real impact also in the risk of treatment-resistant depression. And if the patient failure to the first antidepressant treatment will increase the risk of treatment-resistant depression, and also the patients that we start earlier. So you have some data that you can identify who will be the patients with treatment-resistant depression. You can predict these. We published some papers around biomarkers that you can predict as well in correlating these with personality disorders and early life stress. Next, please. So when I did my PhD almost 15 years ago now, we used this scale here from Michael Tace and John Rush, to try to classify the different stages of treatment-resistant depression. So stage 1 is failure to at least one clinical trial. Stage 2 is fail to or to be resistant to another adequate trial, but in a different class, used in the stage 1. Stage 3 is failure when you use old and more potent, but with more side effects, drugs like tricycle, or stage 4 monoamine oxidase inhibitor. In stage 5, if it failure also to ECT in a bilateral approach. So this was the stage that we used in the past. And the next slide, please. We can see the Mosley staging model that Abe, Tony, and our colleagues developed to stage TRD, the Mosley staging model. That they had the model that consists mainly important factors that can be related to this. We are adding here the Mosley staging model the duration of the episode, so the severity of each episode, and the number of failed treatments. So you see is much more specify more details about the specific course of these patients. The model doesn't include psychosocial stressors. This is a problem, functional impair, or comorbidities. The model was validated in a follow-up, showing significant association with the persistence of depressive disorder in these patients with treatment-resistant depression. The next, please. So the problem of this concept, treatment-resistant depression, is that this was conceptualized based on just a medical model, So usually treatment-resistant was based on cancer disorders, cancer oncology that are focused on cure. But if you consider that depression is a disorder that you cannot have cure for most of the time, you possibly need to change this concept, because the treatment goal of this approach of TRD concept is the sustained asymptomatic state accompanied by return to the premorbid level. And most of the patient could say to us, "Oh, I'm feeling much better, doctor, but I still not can recover my my cognition to read the book in a nice way, to have concentration." So they could not return to the premorbid level of functioning. And this is something that I mentioned about the classic study from Eugene Peko. They keep residual symptoms. The next slide, please. So John Rush, that developed the concept of TRD, developed this new concept recently that is the difficult to treat depression. So I think this is an interesting model because you can also integrate the collaboration of the patient, the family, the physician, the psychotherapist, in try to approach this in a dimensional way. So try to optimize the symptom control, minimize the impact of the main symptoms in the quality of life of this patient, try to improve these in a biopsychosocial point of view, as I said, the TRD is mainly biological, biomedical, and looking for cure. But unfortunately, you are a little bit far from the cure of severe depressive episode. And so try to use this concept of chronic illness for depression will help more the patients and the family members to understand and to carry on with this treatment. The next, please. So you can see here this concept of difficult to treat depression propose the personalize the depressive episode. And so you can have the personality of the patients that can be integrated, the history of genetics, the family history of depressive or mental illness, what I mentioned before, the childhood trauma of these patients, if they suffer from early life stressful situation, abuse or neglect, the psychosocial environmental that the patient is, the support that he is receiving, and also some specific points about the illness, is really a unipolar depressive episode, or you can say that you have comorbidities related to this unipolar episode. You have substance abuse. This is a chronic illness for a long time, is recurrent with or without psychosis, and the age of onset is really important to characterize this illness factor. And then you see the third dimension point is really the TRD points, so this is the reason that the difficult to treat depression integrate two other more personalized dimension factors. The treatment factor is what you have seen by this concept of TRD, number of failed treatments, nature of treatments, if the patient use drugs, which drug they use, they combine with psychotherapy or not, they use a neurostimulation, ECT, how long they respond or not, the quality of the past treatment, the tolerability, the adherence. So these are important factors that you can combine to have a better picture why this specific patient is so difficult to treat, why the response is so low. So you can then propose a better plan for each patient using this dimensional approach. The next, please. So here we have an example of a patient that is part of our routine is a patient with difficult to treat, that the first depressive episode was around 20 before 30 years old, very chronic and frequent episodes with higher chance of family history of depression. Usually you can see several members of the family have a history of depressive episode or alcohol and drug abuse as well. More residual symptoms even when better. The patient improved with some treatment. I had a very good approach combining two different medications that I mentioned in the end of my talk here, but I still do not improve my cognition or my insomnia, So these patients tend to have residual symptoms, chronicity, and also tend to combine several different medications with a very poor function of quality of life. These patients usually describe suicide behavior. This is possibly the red light that you should be aware in these situations, And they only not have psychiatric comorbidity, but as I said, other medical comorbidity like metabolic syndrome, cardiovascular problems, neurological problems, endocrine problems, inflammatory problems, cancer, and others. And they are very expensive for the service. Next, please. So moving to possibly the interesting part, what you can do. What is the arsenal that you have available to treat this so severe situation? You still using in the National Affective Disorders Service in at the mildly advanced treatment service, old drugs, they are more potent in most of the cases than the new drugs. Monoamine oxidase inhibitor is amazing. Phenelzine mainly, tranylcypromide, you can include it here as well. Both that are irreversible MAOIs are much better than moclobemide for treatment-resistant depression. Tricycles like clomipramine, imipramine, amitriptyline are very good for psychotic depression. SSRIs you are using in combination now with ketamine and other new medications that you have seen that can be very useful for very severe depressive episode. Receptor antagonist, mirtazapine, as you know, is very useful medication for patients with anorexia and insomnia, but patients with weight gain and also obesity and hypersomnia is not the best medication. Venlafaxine, we developed in the NICE several clinical trials with venlafaxine demonstrate that it possibly is the closest one to the older drugs with more potent effect. Quetiapine, you are developing a very interesting study now with combining lithium or quetiapine with previous medications that patients are using for TRD. Bupropion is an interesting medication that can correlate to what Dave Nutt described, try to improve the decrease in the positive effect, low energy, low cognition. This bupropion is a PD that is not licensed in the UK, but the Royal College support the use in some subtypes of patients. Agomelatine can help as an adjunctive for patients with insomnia as well. We have more recent drugs. Vilazodone is a 5-HT1 agonist that can help some patients, and also vortioxetine, that is a multimodal, possibly the first of a class of multimodal, is helpful medication as well. The next one. So according to the guidelines for the BAP that Tony Clear and others publish, we are preparing a new review soon for the new guidelines for the BAP. I could say that there's a small superiority from these old medications, like I mentioned, amitriptyline and clomipramine, and also imipramine, if you're comparing SSRIs in patients with severe depressive episodes. The classical MAOIs, like I mentioned, phenelzine and tranylcypromine, are better than tricyclics for atypical depression. So there's some evidence that atypical depression, craving for carbohydrates, hypersomnia, fatigue, respond much better than to MAOIs than tricycles. And very small superiority of venlafaxine over the other dual acting drugs like duloxetine. And you can see also that the noradrenergic medications are better for biological symptoms to improve energy and vegetative symptoms. But on the other hand, the SSRIs are better to improve cognition and memory and concentrations in some of these patients. The next, please. So one of the points that you can come when you're thinking about TRD is the point that you should combine medication. Of course, you should avoid polypharmacy, but in some patients, this is something that you should think about. And the first line, according to the BAP guidelines, is try to combine the current antidepressant, like say SSRI, with quetiapine, aripiprazole, or lithium. The most important evidence is with lithium, but you are having now some good evidence with quetiapine as well. And depends on the patient. Aripiprazole could be useful for patients with metabolic syndrome or any other situations that quetiapine and lithium can impair. Second line, you have risperidone or olanzapine that are two antipsychotics, as you know. Thyroid hormone can be helpful in some patients, and mirtazapine in that circumstances that I mentioned. Give a click, please, Sophia. Other additions that can be considered, as I mentioned, was bupropion, to decrease anxiety, buspirone, lamotrigine in bipolar depression, and tryptophan can be useful. Lower evidence for tryptophan. Modafinil, you have some patients that respond really well the combination in augmentations options of modafinil or other stimulants. Women in the menopause is really another important point. You can see that some women will have a benefit of estrogen or estradiol, and some men as well with testosterone if they have low levels. But you see, this is straight off recommendations and is decreasing the levels of evidences according to the letters that I put it here. I'm quite sure that you have access to these slides later. The next one, please. So you have new medications coming, and the point is that you are exploring new mechanisms of actions, like NMDA receptor antagonists, like quetiapine, ketamine, riluzole is another one that is in clinical trial. Unfortunately, not very good results. You have NMDA, NR2B receptor antagonists that's showing promising. Scopolamine that we are developing now a new trial comparing scopolamine with ketamine, and vasopressin antagonist. That is something that is coming back again. I think for a long time you've been far from the hormone medications, HPXs, hypothalamic, and now you're coming with new medications like this one, nelivaptan, that are showing interesting results, and possibly others that will be related to HPXs and some hormones like ACTH and cortisol. Next one, please. This is an interesting medication. Brexanolone was the first one that was approved by FDA to treat postpartum depression. Several of our patients at the Maudsley Advanced Treatment Service had a history of postpartum depression. So if you can prevent this using this medication, it will be really impacting. Actually, it's an IV medication and is difficult to use and very expensive. And now you are developing a trial phase 3 with a similar but oral formulation that possibly can be very useful for these patients as well, but other major depressive episodes. So yeah, I think you need to prevent this relapse. The next one. We are studying and using the esketamine intranasal in some patients combined with SSRI, SNRI, and you are using also the ketamine subcutaneous and the ketamine IV with very interesting results in combination with of other medications in treatment-resistant depressive patients. We have seen that different approaches are really different. If you are using the esketamine intranasal, it's completely different than using the esketamine sublingual. The absorption and the side effects as well. You are using ketamine subcutaneous, have a different approach, and you are starting to using in some patients ketamine IV. So there's different pharmacological options for similar approach for the glutamatergic and opioid system that can help these very severe patients. You can see here in this graphic that they have a very dramatic effect, so in the first hour the patients really improve, and some studies from Johnson demonstrate that they can keep well for a long time without relapse. And FDA in US already approved it for suicide behavior, not only for TRD, but for patients with suicide behavior. Let's wait and see what NICE decided, and if you can have this approach as well in UK. The next one, please. So, of course, you cannot forget about neurostimulation. No, I'm the lead consultant for the Maudsley ECT service, and you have seen dramatically improvement in patients. We need to decrease the stigma for ECT that is really effective for managing TRD patients. VNS can help some patients as well. TMS have lower efficacy comparing with ECT, but can help some patients. And magnetic seizure therapy is in development, is an investigational treatment. Next one, please. So I'm finishing here. We have the future, the future is good. I think you can have light in the end of the tunnel because as a consultant for many years, I think it's the first time that you have so many medications that can help these very severe patients, difficult to treat, with new mechanisms of actions, and some of them have immediate action. Some of them also have a great impact in help the patients to engage in psychotherapy. It's really important to keep this in mind. I did my training in CBT as well with Aaron Beck Institute in Philadelphia, and we know that patients with depression have a better outcome if they combine with psychotherapy, mainly CBT, and the right medication at the right time. So one of the focus is try to treat these patients in episodes, try to solve the situation, try to prevent relapse, treating them to full functional recovery, and then improve them quality of life. The next one. So this is the biosocial lifestyle model. We adapted this from Jim Marley. You can see here, of course, lifestyle treatments help of these patients as well. We need to help them to increase this psychoeducation approach, not only for the patients, but the family members, community groups, care coordinators, and all the things that you can include these patients, and also psychosocial treatment is really important, CBT, but also interpersonal therapy. This is related to relationship. Mindfulness have some data already, and if they have comorbidity with personality disorder, DBT or schema therapy can help. And then you have these new approach that are coming that I mentioned related to medication, but also keep in mind the ECT and other neuromodulation. The next one, please. One of the points that is important to emphasize is when you have these treatment-resistant patients that are not responding well to any medication, to any combination, the first thing to do is try to review the diagnosis. You need to review and to assess properly any possible comorbidity that is possibly impacting the treatment outcome. So when you have these already defined, you need to review if the patient and the family members are really using the treatment. Adherence is something that is really impacting. Most of you know that sometimes it's difficult to take medication in the right time, the right dose for long times, and the patients with depression possibly cannot do this, especially if they have cognitive impairment. And then I just this switch, like I said, and following the guidelines. And but of course, any case is a different case, and so sometimes it's necessary to ask for second opinion in reference services like us. The next one, please. That's the reason that we settled this service, the Maudsley Advanced Treatment Service in Resistant Affective Disorders, is you call the MATS. The MATS operate at the Maudsley, the South London and Maudsley National Affective Disorder Service. It's a fast-track, simplified referral that you can receive referral from all the country, and you try to provide complex recommendation, difficult to treat for treatment-resistant depression, treatment-resistant bipolar depression. You assess, recommend follow-ups, and also can provide advanced treatment like ECT, ketamine, VNS, and also other approaches related to new pharmacotherapy. You can do like this continuous education and try to help these patients to continue improve, try to reach full functional recovery as possible and decrease as much as you can the relapse in this very severe course. The next one, please. Yeah, this is the service. You can see a small picture of the Maudsley in our facilities, and then you can have 3 patients per hour here for the ketamine clinic. It's ketamine clinic, and you integrate these with the other service related to assessment and also ECT and VNS. Unfortunately, you are not seeing patients face-to-face at the moment, but I hope you can restart to do this as soon as possible. But you're still running the service for the ketamine clinic face-to-face and the ECT as well. But the online you're doing online assessment at the moment. The next, please. Yeah, I usually put a sound for the patients to receive the ketamine infusion or this ketamine intranasal in the area. They usually sit in chairs like these, and they just relax receiving these, and you have very good results. Several patients that do not respond to very complex psychopharmacotherapy, when you combine ketamine or this ketamine intranasal, you see a huge difference. Next one, please. So just to summarize, the development of TRDs is really important, you know, but you should consider other factors like comorbidity in these patients, review diagnosis, and ask about early life experience, childhood trauma. These patients are really important to try to reach remission. This will prevent future relapse, you know, and then the treatment efficacy will be much better for them. Of course, you need to identify, this is what we are doing as well in our service, to combine this with research, identifying biomarkers that can predict relapse or predict resilience is another important point as a predictor for this approach, and try to develop new fast-acting and efficacious treatments, you know. Several treatment strategies are in use, augmentation, combination, dose escalation, switching for different approach. And this concept that I like to keep as a home message as well, difficult to treat depression is an interesting and potentially very helpful way for clinical practice to consider this issue, you know, try to understand. Several papers are coming now, try to compare this concept with TRD. And you are developing new therapies in various stages of development at the moment. The last, I think so, slide, please. Yeah, conclusions, possibilities of new treatment strategies. When you are treating a patient with TRD or difficult to treat depression, you should have in mind what will be the next step, you know, because most of the time this fail, and so you need to understand how you can possibly have a clear structure of your strategy and think about all possible management options, because the patient possibly could not respond, and sometimes this is very urgent and a risk for these patients. So the treatment beyond the guidelines is something important to know, you know, so have a great knowledge of the arsenal of the possible pharmacotherapy approach for these patients, and consider in some cases new treatments, you know. And then that's what we are doing in a specialized service to try to provide for these patients that do not respond to conventional treatment possibilities that are really related to their history and their treatment, previous treatment. The next one, please. Yeah, so this is my last slide, Mike. I just like to thank the Royal College for this opportunity. You have my email address. Keep in touch if you need anything, mario.chiren@kcl.ac.uk, and I'm happy to answer any question if you have time.
Thank you so much. Such a fascinating talk. I must admit, I think the collaborative approach and the phrase difficult to treat really does allow us to engage with patients, service users, care coordinators, and see some positives rather than reflecting potentially on the negatives. We have a couple of questions, if that's okay, Mario. Yeah. People are fascinated by ketamine. That's clear from a look, and I think so. People are excited by that and fascinated. I don't know whether you want to add anything to that. Those thoughts. We also there's a question: what is a virtual lithium clinic, out of interest? And what is the role of lithium in difficult to treat depression in your view, Mario?
Yeah, this is a good point. No, just starting about your first comment, I think ketamine comes as a turning point. You know, it's not really a perfect medication. Have some situations that you can discuss. And when I started studying ketamine, I was thinking that, oh, now you have ketamine that will be our clozapine. We that are working with affective disorders, treatment-resistant depression, you have something like clozapine is for treatment-resistant schizophrenia. Unfortunately, it's not like that. It's less effective, and you have other factors that
Mario, do the
oh,
do your,
again, I
do-
forgot.
do-
Sorry. Now you can hear me better. Yeah, and so like ketamine is not really like clozapine, as I mentioned, but it's really effective. You know, have some efficacy in some treatment-resistant depressive patients, treatment-resistant bipolar that not respond to several combinations like lithium, lamotrigine in bipolar depressive episode, or even unipolar depressive with several different medications, even course of ECT do not respond well, and then when you add ketamine or esketamine intranasal, you can see a good response. Coming to lithium, I think it's really important to say that lithium have a great efficacy in unipolar treatment-resistant depression. I think is the best evidence that you have for augmentation or combination of medications in treatment-resistant depression is with lithium. So lithium is not a medication to use as a monotherapy for unipolar depression, but when you combine lithium with SSRI or other antidepressant, you can see a very important impact in recovery. As I said, the NHR now is funding us with a study that is leading by Professor Tony Clear, that is comparing treatment-resistant depressive approach with lithium and quetiapine. So you can see that both have good results, you know, and this is something that possibly we can have the final data soon, demonstrating that lithium and quetiapine combined with treatment as usual improve treatment-resistant depressive patients. You know, the virtual clinic, that was another question. We are developing another project that we try to monitorize the patients. You know, because you know, lithium is a so amazing medication. Have been used for a long time. Actually, it was the first psychopharmacology approach in the history. You know, and you have seen now that it's not only for bipolar patients type 1, but can prevent suicide ideation, suicide attempts. Is a medication that can decrease the risk of suicide. Also, is a medication that can help patients with history of treatment-resistant unipolar depression combined, and then you are monitoring them with some devices. You have some possibility to use some APP and then follow this patient related to monitoring the lithium plasma levels, for instance, the renal profile and the thyroid function. Most of the time, the GP do not follow exactly the guidelines to assess the lithium plasma levels, review the thyroid function, review the renal profile of these patients as often as the guidelines propose. And so we are trying to propose that this can be really systematized by these APPs. And so we have this virtual clinic that you can monitoring these issues related to lithium in unipolar patients that are with treatment resistant, and in bipolar patients that are using lithium. And definitely you would like to stimulate the use of lithium, that is possibly a very useful medication for these type of patients.
Thank you. Quick fire. Any view on fluoxetine and olanzapine combination for management of difficult to treat depression?
Yeah, this was a proposal from the drug company that have the patent of the two medications, fluoxetine and olanzapine. It's really helpful, you know, but you know, fluoxetine is a very long half-life, and olanzapine have some impact in metabolic syndrome. And so the proposal is not to use for so long time this combination, but there is some evidence that have been demonstrated by several researchers in US, mainly linked with the drug company, and in our clinical practice is useful, but there are many others good combinations of antidepressants and antipsychotic second generation that you can mention.
Mirtazapine and venlafaxine combination.
This is was developed by the great psychopharmacologist Stefan Stahl. They call the California Rocket, and this is really impacting for me. You know, I'm an associate professor, visiting associate professor in Texas University, and I'm seeing here that in London, at least several patients are receiving the combination. This is helpful for some time, but you should think that this medication, like the name say, California Rocket, can really increase anxiety in some patients, increase impulsivity. And if you already try to use this in very high doses, more than 300, 325 or 45 mirtazapine, usually they can increase a lot the anxiety symptoms of some patients that do not respond after some period. So if you keep using this for a long time, the combination of high dose of venlafaxine and high dose of mirtazapine, possibly you can increase severity, the anxiety of these patients, the impulsivity, but not improve the mood of these patients, you know, and this is a problem.
I guess there's something about deprescription and how you come off them as well. Another question just quickly about lamotrigine and unipolar as opposed to bipolar disorder. Your thoughts?
Yeah, I just saw the talk from Steve about personality disorders. You know, you have seen that the comorbidity between bipolar patients with bipolar depression and personality disorders, lamotrigine can help, you know, mainly in the depressive episode. But unipolar, you try to use, there's not so many evidence, and you have some side effects, and possibly have medications with lower side effects and lower risk that can have a better evidence to using unipolar patients than lamotrigine. But there's some patients that have benefit in my experience as well. But the evidence in the literature is very low.
Immunomodulators in difficult to treat depression.
Yeah, this is something that is really coming, you know, immunomodulators that demonstrate minoxidil and others. You have seen more studies in bipolar patients at the moment, bipolar depressive patients that can demonstrate these. If you think about immunomodulators, you can think that immune system is most of the time is a reaction. So if you have a reaction across something that is infecting or a stressful event, can impact in the immune system. And then you can think primarily in the HPA axis, that is our endogenous anti-inflammatory system. And this is a good news that are coming back after a long time that we study HPA axis. The drug companies are putting in the pipeline phase 3 new medications that will act in the HPA axis, and then you impact in the immune system directly.
Thank you. I'm going to finish on this last question, actually. It's a comment and a question. I wonder if the chronic illness model dialogue with the patient could have a risk of increasing their sense of hopelessness or of ever getting better. But I suppose balancing this with a measured, honest, continued clinician endeavoring to work with the therapeutic alliance and trust is established. I think that's something about relational security, but also a bit about the labels, and we wondered what your thoughts were on this.
This is a very good question from Dr. Mullen. I think one of the points is that the difficult to treat concept are treating patients with the history that you need to focus on the present. You know, you need to try to help the patients to have a better relief from the main symptoms, the quality of life. Because if this patient reach this concept of chronic illness, is like diabetes, like hypertension, like other chronic illness. Of course, you should manage, because hopelessness is another symptom of depression. So you need always to give hope to the patients with the possible new approaches that are coming, but treat this as one of the focus on the present, on the main situation that the patient is suffering, to try to improve the outcome now. And I agree. I think the therapeutic alliance will be better for this, because it's worse if you can give wrong hopes to these patients. You know, you can give some possibility that you cannot follow.
I agree. Relational security and having one person doing with the treatment rather than lots of people can make a significant difference. Mario, thank you so much for such a fascinating talk again today. Much appreciated. There's so much rich learning which we can take away. With your permission, there are a few other questions that we'll send to you after the event for you to answer, and we'll send them on to our delegates. So I'd like to say thank you to all our speakers, Dr. Pearce, Professor Baldwin, and Dr. Urena. Thank you for all those behind the scenes, to Karen, to Sophia, to Ashley, and to Fatma. Thank you so much for you all for attending. I hope you enjoyed it. I must admit, I've loved it. So thank you, everybody. Please complete the feedback form. A link will be in the chat now, but we'll also send it out following the event. And a reminder that we're meeting again tomorrow for our session on CSER application and forging a new career potentially. So with that, we are now closing the event. Please stay well and stay safe, and we'll see you again tomorrow. Thank you.